Kayla is currently studying medicine at University College Cork and is pursuing part-time research in the area of advanced care directives in community dwelling older adults. And she's supervised by Professor William Malloy and Dr. Nicola Cornali at the Centre for Gerontology and Rehabilitation. She plans to incorporate her interests into improving health outcomes for older adults in her future medical career. And we welcome Kayla here this morning to present her presentation on advanced care directives in the community. Thank you.
Thank you. So like Mary said, I'm Kayla. It's very nice to be here. So, okay, just a brief overview of what I'm going to speak about. So we're going to talk about a good death, how a good death relates to advanced care directives, where we're at in Ireland in terms of what's going on with advanced care directives, and then what to expect in the future. And I'll talk a little bit about the research that I've been doing. Okay, so when you see these words, a good death, what does it mean to you? To many people, a good death means dying somewhere where they're comfortable, being surrounded by loved ones, and being in the absence of distressing physical symptoms like pain, trouble breathing, or nausea. Now, with our aging population, with the ever-increasing medical advances, how is a good death changing? So a recent Irish Hospice Foundation did a survey and found that while 3 out of 4 people would prefer to die at home, only 4 out of 10 people actually do die at home. So is there a disconnect? Why is there a disconnect? Looking back, going backwards, we know that as we age, we're more likely to acquire illness, to acquire some sort of disability. And what I'm interested in looking at is where the division is between what's an acceptable disability, an acceptable quality of life, and what's unacceptable. So for many people, it's easier to put this into tangible terms, so we can use an example like eating and nutrition. So somebody might say, well, as long as I can taste food in my mouth, that's acceptable to me. But if I can't taste the food in my mouth, that's unacceptable. So what that would mean would be that somebody would find the idea of having a feeding tube, a tube into their stomach, permanently unacceptable, and they wouldn't want to cross that line. And these lines are very individual. Each person has their own opinions, own values, but it's really important for somebody to think about what their opinion is when it comes to crafting an advanced care directive. So what is an advanced care directive? Some people know it as a living will. And basically it's a document that allows an individual to make a decision about how they would like to be treated in the future, should a time come when in the future they're unable to communicate their wishes. So it's a document that people make when they're capable and in relatively good health that would govern their treatment in the future if they should decline and be unable to make decisions. And it only is applicable if that state arrives in the future. So basically it's really important because it extends an individual's control to a point in their life where they previously would have lost control. And I hope that you can see in the next example that I'm going to give that it allows somebody to achieve a good death in accordance with their own wishes. So I'm going to walk through an example where a clinical scenario where an advanced care directive would have been useful, and then come back and speak a little bit more about it. Okay, so this is fictional. Mr. Murphy is an 84-year-old gentleman living in an assisted living facility. He's had Alzheimer's disease, so he's had dementia for 7 years, and it's severe enough that he's unable to recognize his children and only sometimes recognizes his wife. He needs assistance with mobilizing, and he's become incontinent. Okay, so quite severe. Then one day, Mr. Murphy suddenly has episodes of hematemesis, so he's vomiting blood, and he becomes very hypotensive. So the situation is dire, really, and unless he's treated with some sort of intervention, he will most likely die. For whatever reason, his family aren't available to be contacted, and he had not made an advance directive prior to becoming ill. So we have no idea what his wishes are. What would you do? So if you're the healthcare assistant, or if you're the nurse, or you're the director of this home, what would you do with Mr. Murphy? So there's 4 choices. The specifics aren't so important, but there's 4 levels of care basically. There's palliative, so that means providing comfort measures only, okay, but not making an intervention to try to save Mr. Murphy's life. There's limited care, so that would involve transferring him to a hospital and some limited kind of therapy. There's surgical care if necessary, and then there's intensive care. So we're increasing in intensity. Now, this same situation was presented to over 1,000 nurses in 5 different countries, Ireland included, and they were asked, what level of care would you give to Mr. Murphy if he was your patient? What level of care would you give to him if he was your father? And what level of care would you want if it was yourself? So you might want to take a second and just think to yourself, what would you choose? The nurses responded, and here's what we get. So this is the breakdown. If this was your patient, this is what would be done. If it was your father, and if this was yourself. Okay, so what's really interesting to see is that we choose differently for our patients than we would for a family member or for ourselves. Okay, and why this matters is in Mr. Murphy's situation, he hadn't made his wishes known, and there's a potential discordance between what he would have wanted and what happens. So why does this happen? There's a lot of reasons. The healthcare providers have their own particular life experiences and beliefs that they're acting on. Age comes into it. Sometimes religiosity and spirituality come into it as well. And healthcare providers also perceive a particular duty of care. So there's a host of different reasons, but I hope you can see now that had Mr. Murphy had an advanced care directive, then the decision that would have been made, people hopefully would have felt confident about. So an advanced care directive, there's 2 components to it. They go hand in hand. The first is an instructional component. So this is documenting and writing what interventions you would want, what interventions you wouldn't want. And it can be as vague, as general, or as specific as you want. It can deal with all sorts of things like particular interventions like feeding, CPR, breathing, but it can also deal with things like where you would want to be living. So what kind of facility you would want to live in should you acquire dementia. The second component is assigning a proxy or a power of attorney who will carry out your wishes. And actually the 2 go hand in hand, so ideally the proxy, the person that you assign to carry out your wishes, should be there when you construct the document so that everybody is clear. So more evidence for the benefits of advanced care planning. If there's evidence, it improves the end-of-life care. It reduces family stress, anxiety, and depression. So you can imagine if there are disagreements between children or between children and a spouse about what this person would have wanted. When they were asked, older people want to be consulted and they believe it's important that they're in control. And as well, healthcare practitioners also think it's a good idea. What potentially is very important today is to see that the presence of advanced care directives actually reduces the transfer of dying patients to a hospital. So it reduces the unnecessary intervention, and I suppose money comes into play, but money isn't totally part of it. So one study in Australia showed that it reduced transfer by over 22%, and in the UK from 15 to 8%. So currently in Ireland, there's no legislation for advanced directives, but what is recognized and has been for a long time in case law is the right of people, or the right of patients to refuse treatment. What's currently not legal, I suppose, is to nominate a proxy to carry out one's wishes, but there have been rumblings. Here's a nice quote from former Minister of Health. And we're actually in the process of making history. So over a year ago, there was a draft added to the Assisted Decision Making or Capacity Bill of 2013, and this was a draft for the inclusion of advanced care directives. Public consultation was sought after this draft was released, and over 60 groups and individuals submitted recommendations. Generally, people were very supportive of it, and there is still some work that needs to be done. It's not a perfect process. One particular recommendation from the IMO was that an advanced care directive should be made on the basis of informed decision making, so informed consent. So the patient should have some idea what could befall them, and to accomplish this, we need advice from a medical professional or someone who has the training to guide the patient. So we're going to need additional training for GPs, for medical specialists, for directors of homes to help patients complete these forms. And obviously we're anticipating some barriers. So a review of the literature kind of reveals these 4 main areas as barriers to the completion of advanced care directives, and I'll go over each one of them in turn. So awareness. So even in America, in the United States, where advanced care directives have been around for a lot longer, nobody really knows about them. I think the 30% is the highest prevalence rate that I've seen, where random people are surveyed and are asked if they've ever heard of advanced care directives. Ireland, it's very similar to this. Was a study done in 2010 with an Irish population, and I'll just highlight that circle number. Only 71% had heard of the term advanced directive. More people, when they think about end-of-life care, they automatically, their minds jump to DNR, do not resuscitate. But it doesn't have to be that dramatic. It's not saying that making an advanced care directive is going to a DNR. Another huge barrier is the perceived irrelevance. So many people say, well, why would I make a document? Why do I want to engage with this process? It's futile. So over 88% of, again, Irish people surveyed said that it's not better to express their wishes in advance because their family will make the decisions when the time is needed.
Does the doctor in charge of the patient have the final call, or is it the family?
Do you mean when an event happens?
Well, when the decision has to be made about a very infirm relation, who, if let's say the son says, I would like my father to be able to die in peace, can the doctor at this moment step in and say, no, that's not going to happen, I am in charge? Who actually is in charge of the fate of the patient? Is it the family or is it the doctor?
To be honest, I'm not sure. I think at the moment it's a collaboration, and I'd say they try as best they can to do what the patient would have wanted. So if the patient had at any point in time even verbalized a particular wish, then that wish is respected.
Just the list of brothers there.
I'm a colleague of Kayla, so I work in the Centre for Gerontology, and I've been working with Dr. Nicola Cornelli and Professor William Malloy on some of the advanced care planning research. And the obligation is legally with the consultant, the medical consultant, until this new assisted living or decision making, bill is passed.
Thank you. That was a very interesting presentation, Declan Murphy. I hope I don't suffer the same fate as your example in your part of it. I'm interested in the training element of this. If you say that home care staff or frontline staff, obviously it's a very sensitive conversation to start having with somebody who's reaching that stage in their lives. Where do carers acquire the expertise to be able to start that conversation when it's appropriate?
So in Cork, Nicola, one of our colleagues, has been working with Homecare, assisted living, and long-term care facilities.
So as part of this project, they ran a before and after study. At the moment, they've just received funding from the Health Research Board to do a randomised control trial to develop that further. And within the before-after study, they developed a comprehensive palliative care and advanced care planning education program, and they implemented it across, I think it was 6 care homes. So it was like, they had 2 different aspects to the training from what I can remember. One of them was for all of the staff, including, not just the healthcare staff, the kitchen staff, across the board, and that was in terms of the palliative care approach. And then they had, for senior nursing staff, they had an advanced care planning program, so to enable them to actually deliver advanced care planning with residents and their family members. So that's actually being developed and tested at the moment in a randomised control trial. Yeah. And I suppose the hope would be that it would be implemented beyond long-term care and into the community. So, yeah.
And I believe, I heard yesterday at a conference as well, the capacity bill, and I'm not sure if the advanced directive part of that is with the government Directive at the moment, because that bill has been sitting there for quite a while. It's not gone through legislation. So,
in the home setting, you mentioned the GP a few times. I'm just wondering, is GP, would that be necessary, or if somebody decided, say now, they wanted to make plans? I know it's not legal as such, but would it have to be GP part of it, or can somebody at this stage draw up wishes, or it's a bit broad what I'm asking, but just because you mentioned GP a few times as part of it, I'm just wondering.
I suppose at the moment, because there is no legislation, somebody could drop a plan and write it out. I don't know how legally binding that would be, and in fact, in the IMO's recommendation, they recommended that these contracts, even if it does go through legislation, that they're not legally binding. I suppose the point of having a GP, or it doesn't have to be a GP, it has to be somebody knowledgeable, is that they can explain things to the patient or the person, and that operates on the principle of informed consent. Because if somebody with no experience and with very limited knowledge made a plan but had no idea what could befall them, then I don't know. I don't really know. Did that kind of answer your question?
In relation to the whispering or the conversations,
Yeah.
maybe people maybe with a medical background needn't necessarily maybe be a GP, but would be able to direct or be able to listen or be able to, I know there might be possibility of maybe not correct information or something, or taking it down correctly, but and I also know it's not legal, so I suppose that this is in the preparatory kind of stage. Yeah.
but Elizabeth, I mean, couldn't we put a power of attorney, our wishes? Yeah. So.
GP just now and writing an advanced care directive, is that kind of what you're? No, sorry.
I belong to a group of I'm actually a Mercy sister, and I work with I'm a retired public health nurse, and I spend time with some of our older sisters, and that's what I'm involved in now, and maybe helping towards getting care packages and maintaining people as long as possible at home. But sometimes maybe they end up in hospital, and maybe they haven't talked through or expressed, and just wonder, as a group of people, and in the light of statistics we were shown today, we are a very ageing group of people, as in planning for future planning, how to go about that, I suppose. That's my question, really.
Yeah, I understand what you're saying. So I think that, like, if you were to as working within the environment that you work in, or discussing with the people that you're caring for, you could probably, I've heard of cases where people have created their own advanced care directive, but I suppose it has to be, what we would advocate is that it's done in, I suppose, with the healthcare professional and with maybe a solicitor or something like that, to make it more binding, until this is kind of all ironed out in terms of legislation and stuff. And as well, the other thing to point out on that is that it's very important that the person, when they're making their decisions in terms of their future wishes for care, that they have the capacity to do that, and that has to be assessed as well. And in the programme that's been run out at the moment, there is a capacity assessment that is done before the person completes the advanced care plan. And if the person is deemed to be, not have the capacity to complete due to maybe cognitive impairment or whatever it might be, it's a different type of a plan. It's an end-of-life care plan that is done with the family and the GP. Yeah.
Thank you very much for that. So